Hey everybody, Dr. Rob Silverman here. I've got one of my favorite guys, favorite doctors in the whole wide world, Dr. Mitch Malley here. This man is an expert in the joint biomechanics, adjustment, and overall health and well-being. Dr. Malley, thanks for taking some time to come out and chat with me.
It's great to be here, Dr. Silverman. You're a legend yourself, sir.
Yeah, there you go. Exactly. Let's jump right in. I mean, you are without question an expert in joint manipulation. You have over 40 years of clinical practice. You've treated Olympic athletes, professional athletes, well-known celebrities, etc. Other chiropractors like myself have come to you to ask, for guidance, some insight into a joint by joint approach. So many of my patients ask me, do we look as chiropractors and manual therapists, do we look just at the area of the joint, the area of symptom, or do we look at the whole body?
Really a great question. And we like to look at the whole body. There are 206 bones in the human body. Actually, half of those bones are actually in your hands and your feet, 25% in each of the feet and hands. So when you look at those areas, they're often neglected. They're just overlooked and undertreated. Many conditions, as you know, are in the feet: plantar fasciitis, heel spurs, Achilles tendon problems, bunions, Morton's neuroma. Those are the most common things you see in the feet and in the wrists and hands. Carpal tunnel syndrome, cumulative trauma, trigger finger, and a myriad of other conditions. So we like to look at the entire human body, and it's much like building a house. You wouldn't say to the architect, let's just look at the bedrooms. The architect is going to get a complete rendering of the entire aspect, looking at what that home would look like when it's completed, and breaks it down to the very, very basics. The same we like to do when we do human biomechanics and engineering of the structure.
So you're looking at the whole body and you're looking at the foundation, and you make a real salient point in the idea that half of the bones in the body are in your extremities, or at least your hands and your feet. Most people don't know that, because they look at chiropractors as being just spine oriented.
That's true. And one of the most salient points to consider is what the National Institute of Health said. Last year, $800 billion was spent for pain suffering, and pain syndromes. When you extrapolate those numbers, it's fascinating that 400 billion, half, was just head, neck, and low back pain. Dr. Silverman, the remaining 400 billion, the other half, was all the extremities, an area often neglected and not well understood by many practitioners. In fact, chiropractic colleges, many of them only have maybe one, possibly two courses on extremities.
Well, we're not going to get into the why, but I'm going to get into asking you, which conditions do you think are vastly overlooked? Or, let me serve one up for you. Plantar fasciitis, which is really a misnomer. Why don't you take us through the idea of plantar fasciitis, how common it is, how to assess it, how to treat it?
Sure. Plantar fasciitis, if I use this bone model of the foot, you can see beneath the foot this area of tissue that connects to the heel, but also extends to the ball of the foot. For the sake of demonstration, plantar fasciitis is inflammation on the bottom of the foot. And most literature talks about the fact that the person needs to stretch the foot to ameliorate the condition. Well, the problem is the foot is already collapsed, the arches have failed, and the person is what's called an overpronator, and that with the collapse of the arch is already overstretching the plantar fascia. So it would be prudent for you to understand that if you were holding a spring and I'm holding a spring, and that spring is stretched, to fix it, you wouldn't stretch it some more. And this is why we see so many cases in my concierge care program of patients that fly in from all over the world, Doc, and they've tried everything. They've stretched it. I have a patient who wore every boot, shoe, stretch, injection, platelets, stem cells, have done everything, including the topaz surgery, which she had 38 holes drilled in the bottom of her foot. Doc, I don't understand. It's very simple. When we correct the alignment of the bones of the foot in a painless, again, I reiterate, a painless procedure of manipulating the bones of the foot, the first thing people like to do is they like to bring their heel to the ball of the foot, which is counterintuitive because they've been told by every book and magazine and infomercials, content online, etc., to stretch, continue stretching. But then why do the podiatrists and orthopedists and PTs then tell you after you're stretching, we need to now put you in an arch support? Well, which one is it? You want to stretch it or put a support? So I suppose if you do both, you might get better. But the problem that I've seen in over 40 years and thousands of these cases is the fact that the heel bone is not where it belongs. It's the bone that when you twist your ankle gets rotated, misaligned, like the front end of your car when a wheel gets out of alignment. You don't just change the tire because the car is not performing right. May do a wheel alignment. That's what we do.
Interesting. So plantar fasciitis is not necessarily true tension in the muscle or the fascia in the bottom of the foot. The cause, because we're always looking for root cause, is your inability or the fact that you're in overpronation. Could you define pronation for everybody?
Sure. If this is the foot, your foot will collapse inward. So in this bone model, pronation, if this is the front of the foot, pronation would be collapsing of the foot downward. And that happens because of the improper hindfoot. Hindfoot mechanics changes, the misalignment of the heel goes upward, collapses the arch and causes overpronation, thereby stretching the plantar fascia. So in our world as chiropractors, you know that you said it very eloquently, we look for the root source of the problem. In most cases, people's feet, 26 bones in the foot, kind of similar to the spine, isn't it? Leaving any bone untouched in the spine or in the feet can lead to a myriad of other complaints.
Now, you said that the heel bone, the calcaneus, is implicated in an ankle sprain, and usually it's an inversion, anterior talar ligament injury, etc. Not trying to worry everybody with some anatomy technicalities. However, so you're telling me that a lot of plantar fasciitis is post-ankle sprain as well.
Post-ankle sprain could be acute or it can be chronic repetitive. You could have been born with malalignment in your feet, which not acute, but is developed over time. And as a child grows, the myth of growing pains is funny when patients come in and the mother says, could you explain why Johnny has growing pains? I said, ma'am, where is his pains? Johnny, where are your pains? My left knee. So is the right knee not growing? So it is what I call a mistake. It's a myth, and there are functional facts and fictional fantasies. So let's take a look at the foot in an upright position. And when you sprain the ankle, what happens is that misalignment is the beginning of the most problems that develop in a person's foot. Putting those bones back in normal position doesn't hurt. However, if it's an acute ankle sprain, we do ice it, freeze it down a little bit so we can set it. It's kind of like a dislocated shoulder. You don't wait for the swelling to go away. Right. We all know that swelling is the body's attempt to brace and protect an area that's been traumatized. So most importantly, doctors that I train around the world ask me, they go, Doc, do you adjust sprained ankles right when it happens? I said, absolutely. It's no different than a dislocated shoulder. It's imperative to get that joint restoration to allow healing to occur rapidly.
So you're saying that as long as the bones are in alignment, the associated tissues, ligaments, tendons, etc., have a better chance of healing because there's no strain on them and not a rise in inflammation.
Absolutely. If I can, let me show you a picture of a knee model. And when somebody comes in, Doc, and they say to us, they twisted their knee and they're in a knee immobilizer, a full-length knee immobilizer, and crutches from the orthopedist has said, well, you've got a grade 2, grade 3 sprain strain of the knee, which means it's a twisted knee. My first question is to the patient, you just said you twisted your knee, and underneath that support, isn't it still a twisted knee? Well, yes. Great. Wouldn't it make sense to untwist that knee? I twisted my ankle. Whoever untwisted it. So the very common thing to occur in the rational thought process for a patient is, I sprained it, which means I twisted it. You have to ask yourself, who's ever untwisted it?
Great
now,
point.
You and I had a nice conversation watching a certain basketball team with a player of mine on it. And you've seen how many sprained ankles and knee injuries. And you saw a guy go down with a knee to the back of his head.
That's right.
Okay, yesterday with a little concussion, which is more of your expertise. But when we see these types of twisted joints and you don't put them back in place, the patient's going to end up with what's called recalcitrant, which means chronic. It's not going to get better. In fact, finish the sentence for me, Doc. Once a sprain,
always a sprain,
because it's never been corrected the first place. If the listening audience were to think about a tire gets knocked out of alignment when it hits a chuck hole in a parking lot, the car's performance gets affected and it might veer to one side. You don't add air to the tire. You have to take it into a tire shop and have a front end what? Alignment, a wheel alignment. And I guess in a pun, without taking care of that, you'll have a wheel problem. The jokes aren't that great, but I think you got the point.
I got the point. And, when you think about it, I'm sure everybody right now is going, you're right. Untwisted. I mean, it's simple as if you wrinkled the shirt, got to unwrinkle the shirt before you put it back on. It's the same thing. Now, getting back to plantar fasciitis, a lot of data indicates, and I know you're going to really take this one to task, that plantar fasciitis isn't truly plantar fasciitis. It's tibial tarsal syndrome, and it's a nerve, which is really probably walking right into what you were just talking about the pronation. But it's actually a nerve and not necessarily a muscle. You want to take the baton on that one?
Sure, absolutely. If you do the orthopedic tests, any qualified chiropractor who knows how to perform foot orthopedic exams would easily discern or differentiate between a neurological problem and a soft tissue problem or an osseous problem. It's very clear with thousands that I've treated that I feel very comforted and comfortable stating that on x-ray, I can show you where the misalignments are that are causing and contributing to this problem. Then we measure your pronation stability index number, which gives us an idea how much your foot is turning the wrong way. Coupled with the x-rays and the clinical examination, it's not at all uncommon for patients within a week or even the same day to have tremendous relief for the first time, having suffered plantar fasciitis and tried every imaginable treatment under the sun, until such time that somebody looks at the architectural rendering, the x-rays, and knows how to correct it. And that's been my expertise in developing these methods.
Yeah, that has been definitely your expertise. That kind of falls into what we call the Malley method, which I know you're going to go into. But let's close the loop on plantar fasciitis. Number one reason for heel pain in America. I think it's 10 million Americans at any one time. It's actually misdiagnosed, it's mistreated, and it's actually mislabeled. We got through all that. You got to untwist the thing that got twisted. And for you, the thing that's getting twisted is the heel bone and
other bones of the foot that affect the soft tissue.
You got it. I was hoping you wouldn't give the names, but okay.
So when you think about this, when somebody rolls an ankle, it's just a series of multiple misalignments that stretches a ligament. When people say, come on, doc, don't you even know what a sprain is? I go, absolutely. Overstretching of ligaments. Very good. So the question now is, let me ask you, doesn't a ligament connect two bones? So here's two bones, a ligament connects them, and a sprain by definition means overstretching, partial and or complete tearing of the rubber band called a ligament that connects between two bones. I twisted my knee. Should we then go off of our knee on crutches wearing a mobilizer that's covering up a knee that's twisted? 6 weeks later, for example, you take a car that had a wheel out of alignment. If I told you to help that car and that wheel out of alignment, park it in a garage for 4 weeks, get out of it, get off of it, just the same as they do on an ankle or a knee or a wrist sprain. Don't use it, but it's still misaligned. So 4 weeks later, they go back to the doctor, the therapist, or what have you, and they say, I'm no better. I've done the physical therapy, I've done the splinting, I've done everything, and it's just not any better. That's because you don't put a cart before the horse. You have to understand, real wheel alignment or joint manipulation is to be performed before you take the car out to the Daytona and race it around.
That makes a lot of sense. And it's quite I'm going to say life changing because first you go to chiropractic school and everything's centered on the spine. Then you go out in the real world and you take that spine and you hopefully expand to the extremities as you're talking about. And then you have to make this decision. And I'm going to ask you, how much does an extremity injury affect the spine? Because the spine's attached to the extremity is attached to the spine. Do we look at one, both? I mean, what do we do, Master? I mean, what do we do with that Malley method?
That's such a great question. And it's one that I do to explain what's fancy called a Valix phenomenon. In English, if I ask you this sentence, you finish it. What goes around?
Comes around.
Okay, good. So if the message from the brain, as you know, goes out down my arm to my hand, then when I touch a hot stove, a message should go back to my brain and say, move your finger. There is the difference in the two-lane highway of our nervous system called the efferent that goes out to the periphery, like from the brain out to my hand, but afferently comes back from the hand to the cord in the brain. So a great question for you would be, is if you are going to adjust your patient's low back, wouldn't it make sense to check the foundation of the structure that's causing the plaster to crack? So the low back pain gets treated repeatedly by physical therapists, chiropractors, massage therapists, etc. But when I look at a low back problem, I look at the low back as the weed. I look at the feet as being the seed or the root. When I correct the root source of the problem, those patients who have suffered for years, even live in my audiences on stage, when I bring doctors up, anybody have a low back problem or hip problem? Doesn't get any better. Come on up front. Anybody ever look at your feet or knees? No, doc, it's my low back and it's going down my leg. I've got 2 discs that are bulging. Great, lay down. I manipulate one bone just for fun, just to demonstrate. I manipulate the calcaneus, the heel bone, on one or both feet, get them up walking around, and they go ahead and do a squat right before the audience's eyes and go, my God, my back pain is gone. Pain is just a message. It's kind of like hitting a dashboard to get a gas light to go off. That would be twisted. And you know what's an oxymoron when you think about it for a moment? Look at the word when I say what you said is just not right. It's twisted. So even in the English vocabulary, we know twisted is not right.
Indeed. So you're talking about the foot being the root, and that's not where we look. So, I mean, root cause resolution. What about something called leg length inequality? I mean, patients come in all the time. I think I have one leg longer or shorter than the other. How do you address that? And how does that come in your assessment with the spine, the foot, and all that's going on in the extremities?
I'm so glad you asked me that question. You know, back in the 1800s, published in the Royal Surgeons of England, Dr. John Hilton, MD, neurosurgeon, 1820 to 1840. When he published in 1860, he published an article 35 years before the evolution of chiropractic in 1895. He found from 1840 to 1860, actually, he found in his clinical practice that one limb was shorter than its contralateral fellow. In English, he found that he would stack a bunch of brochures underneath the short leg until the shoulders were balanced, and he would take that and cut a cork-like material, put it into the shoe or work boot, completely ameliorating or getting rid of unnecessary surgical intervention, excessive drug application, as well as treating low back and disc and hip joint and knee problems and sciatica by correcting the limb length. Chiropractic colleges do teach a basic technique, as you know, a Deerfield leg check, where the patient is either prone or supine and you measure the way their legs are. I have done over 10,000 studies now, and the average patient has a 90 to 92% probability of one leg by its measurement shorter than the other. So we don't use a high-speed belt sander on the long leg. What we do is we put a shim underneath a little heel lift, if you would, and that heel lift looks something along the lines of this, that it goes into a person's shoe, or if it's too many heel lifts required in a shoe, then they have to go to a shoe cobbler and have the shoe cobbler do what we call an outsole to make sure that their leg length now when it strikes the ground is even. Now that statistic of 90 to 92% changes if you've had an arthroplasty, if you've had any kind of a knee or hip replacement, or a broken upper or lower leg, can alter the actual bone length called anisomelia. Anisomelia is a fancy word for leg length inequality. So the ones who've had surgical intervention with an arthroplasty, a total knee, total hip, that number is 99.9%. Patient goes back to the surgeon complaining, hey, ever since you did that surgery, something's not right. My back is killing me. The surgeon says the joint's perfect. Go back to physical therapy. I don't know what's causing your back pain, but the joint's perfect. We look at those patients, we evaluate them, and that number is 99.9%. I've only had two since 1991 when I started doing this research. I think I've had only a couple that actually had knee replaced or hip replaced that were actually even. Everybody else, it's been life-changing to do this measurement that I teach around the world called an orthoröntgenogram. And that particular x-ray, we have a procedure with a box that has a lead ruler, and we step the patient up, we measure their leg length, and then we put the heel lift correction underneath their heel and retake the x-ray. And it's fascinating, Doc. You can see pelvises like you and I see like this every day when we x-ray patients, and curvature of the spine called scoliosis. And in 10 seconds, standing on that heel lift, retake the x-ray, not even adjust the patient yet. And you've got a spine that's straightened out and pelvis that's now balanced. We can't even keep these in stock. Doctors who listen and watch and see the results, pre and post x-rays and patient testimonials, well, you can see why that's so prudent, because schools don't teach us this at all.
So to recap, you're using could I call it an orthotic? Would that be fair?
Well, the orthotic actually is just going to be a heel lift. The public might get confused.
Okay.
Heel lift is different than an orthotic. Orthotic might be full length, but it's a heel lift. It's a wedge that goes in your shoe, measured at 3 or 5 millimeters. And there's only so much that could go inside the shoe before you have to take it to a shoe cobbler and have them do the outsole, which is full length for the patient.
I noticed you used an x-ray, but you used an x-ray with gravity. Standing.
Absolutely. Has to be done with standing. Look, your patient, when they get up off the table, they look good on the table. We give ourselves an attaboy or attagirl, do your exam on the table, get them up walking around. By the time they get to the front desk, they're probably having the same misalignment again because the body has to compensate for the short leg.
Interesting, because I don't think most people realize they spend more time on one leg than they do on two legs, and they don't realize what you said, which was a huge takeaway, in that leg length discrepancy is really going to lead to an unleveling of the pelvis, i.e. lower back pain. Whereas somebody like me who's got the congenital torticollis, I have the unleveling of the upper spine. You know, I have lower back pain, but I'm getting it from the top down versus from the bottom up. All that being said, what percentage of people do you believe that have lower back pain have it from misalignment in the foot and or leg length inequality?
The majority. Yeah,
The majority.
I would absolutely say 95 to 99% of everybody. Look, 90 to 92% had leg length inequality contributing to the problem of knee, hip, and low back pain. Then you get into piriformis syndrome, and you have people telling them to stretch a muscle. Well, the muscle's already been overstretched by the rotation of your pelvic bone. So when we talk about the knee rotating, that can cause your IT band pain. But at the top part where it attaches to the pelvis, the femur rotating is going to cause wearing down at the hip joint. What is the two most common replaced joints in the human body, Doc? Knee and hip.
Hip, yeah, without question. And what a great point in the fact that you're saying the unleveling of the leg length equality with the joint replacement. They're smaller. So my dad's got, you should see my dad. Wow. Whew, he's got 3 joint replacements. I mean, he's a step above the Hobbit at this point. It's unbelievable. It's great that they replaced it because it was unusable. But the problem is they never addressed all the inequalities, if you will. And he's proven that it's mind over matter, because theoretically he shouldn't be able to move.
Well, mind over matter, just think about that. His mind is above the matter that has been replaced.
There you go.
Okay, so it's not equal, and therefore you have what breakdown in what the human body, as you and I were taught, two words: dynamic equilibrium.
Mm,
In motion, the body needs to always maintain a level of balance. And the reason why the elderly trip and fall so much isn't the fact that they blame the faulty footwear, which is what they do. In a famous Los Angeles study, the elderly, 86% of those that had fallen with a high morbidity and mortality rate blamed their shoe for dragging, when in fact, it could be the point is that a dent in the fender produces rust. And if you've been walking around on normal, even your whole life, or uneven, and then you get joints replaced, and then you get muscle atrophy and weakness as we get older, these are contributors to why somebody might fall. So you might look at your dad and send them out here, like most of our transient patients that fly in and out. We shoot that x-ray, or you might get that x-ray unit, that package for your office, and start taking those x-rays of every patient that you see, because you too will find out of 100 patients, 9 out of 10 of them have bone length inequality that you
mm.
cannot adjust or manipulate to make them even. You and I know there's two types of short legs. One, misalignment, and we put it back in place and the patient leaves. The other one is it's misaligned, we put it in place, they stand up, that leg is shorter, and they walk to the front desk and make the next appointment. Those are the patients that come in and say, Doc, you've been adjusting my low back for a long, long time. It just doesn't seem to hold. The reason it doesn't hold is that one leg is truly shorter than its other.
And you need to rectify that with what you talked about with the not orthotic, but the heel lift, if you will.
Yep, a new word I use instead of rectify is correctify.
Love it. I love it. Now, you brought up a good point. I didn't know we were going to go here, but that's the beauty of being conversational in podcast is balance. And you spoke about balance. The bulk of people who fall are over 65, and it's one of the leading causes of death for them. And obviously, balance has a direct correlation between your extremities, your lower limb extremities, and your mind over matter. So, what are you looking for in a balance test and a balance correctify, if you will?
So, very good question. We do our complete assessment and evaluation with a 3D scanner. We measure the difference between left and right, your weight bearing difference. We've had people walking with what actually calculated to carrying a 25-pound dumbbell, a weight attached to your right ankle every step you take.
Mm.
So, in the gym, you might think of watching and you'll see people doing lunges. How does that work when you have a 90 to 92% probability of one leg shorter than the other? Your lunge, your stride will be different on your long versus your short leg. So it's aiding and abetting in the patient's complaints. Squats, another thing. If one leg is shorter, I've got two power lifters who had chronic low back pain, very heavy lifting. We're talking 600 pounds. And when we assessed them, did our leg length, we found about both of these two were 3 millimeters difference, Doc. 3 millimeters. Put a little $7 heel lift. And now instead of going down crooked and torquing the pelvis and spine, not only are they no longer in back pain, but their lifting became more proficient and they had better performance as well as prevention.
Fascinating. Great stuff. So we talked about the lower extremities, if you will. Let's pop up to the upper extremities. Let's talk about carpal tunnel syndrome. Is it real? What's the anatomy? Is it a pseudo carpal tunnel like pronator teres? We'll use a fancy word. Is it double crush? I mean, what is it? What commonly is needed to be assessed? And what do you do to help people at your high level for carpal tunnel syndrome?
Well, here's a wrist and hand model. And the carpals are these bones right here that form two rows. And there are 8 bones. This little guy is kind of like the kneecap. And that one just sits inside the tendon of the flexor muscle. So any of these bones, the carpal tunnel by definition, is bone on 3 sides covered on 4th by ligament. So I'm going to use my hand as a concavity. And I'll place it here, and that would be the carpal tunnel inside the wrist. It's bone on 1, 2, 3 sides. covered on the fourth by ligament. So let's use my watch band as the ligament. The nerve and blood vessels and flexor tendons that go to the thumb, index, middle, and inner border of the ring finger is called the median nerve. And the ulnar nerve next to it goes to these last two fingers. What happens in carpal tunnel syndrome, and we do a specialized x-ray, I have a patent on the carpal tunnel exposer that allows me to measure the height, the width, and diameter of the carpal tunnel and shows clearly the bones displaced, pushing on the nerve up to the ligament. So again, let me reiterate, pushing on this nerve up to the ligament doesn't mean you should think about having the ligament bisected in surgery. That's a simple solution. But the problem is it's a paradox. If you cut a ligament, it heals with scar tissue. And the literature will tell you and support the fact that when you have scar tissue developing, it often requires follow-up surgery to remove that scar tissue. My question is, what's going to remove that scar tissue?
Another surgery. So you make a great point. The carpal tunnel surgery results are very poor. At best, they're poor. And they're poor because they're not getting to the root cause, which you're saying is the bone pushing out the nerve or closing the gap between the nerve and the ligament. And also, as you said very succinctly, that when you have surgery, you're also going to have scar tissue in a small little tunnel. That scar tissue is going to close down. And in many instances, the condition is going to be worse than it was before. So with the Malley method, what do we do?
What we're doing is actually we x-ray and determine the misalignments of the carpals, and I very gently and very precisely manipulate or move the bones back off the nerve, and the patient gets better. Look, you can go to my YouTube channel. It's just drmitchmalley.com, M-A-L-L-Y, drmitchmalley.com. You can select videos and peruse some of the cases there. And my Instagram is just at the Malley Method. So if people want to, they can peruse and see some of the really interesting cases that we put up periodically, some really neat ones. Had a baseball player that's a Major League Baseball recruit with a condition called a carpal boss. And Doc, I'm sure that you're probably not familiar with that condition. It is a very specialized, again, something that people who attend my courses are going to learn. That's this bone right here goes out of place just like this, and it creates a bump on the back of your hand off of the second metacarpal, off of this finger. People will have a bump right here, and many people think incorrectly that it's a ganglion cyst, a little cyst. But when it's firm and hard, and you take a look at this on x-ray, you'll see this misalignment. Well, this baseball player has been to the trainer, the doctor, the surgeon, injected it, wants to do surgery, flew up to my office for 10 days. The first day in front of his dad, he took a device which simulates a bat swing. And after we diagnosed and manipulated him, he went ahead and held the bat and swang at a quarter speed, half speed, and full speed that he hasn't done for 4 months. Couldn't hold a bat. Just by restoring alignment of the bone structure. It's kind of like washing your car when you have a gas light that's on the dashboard. Washing the car isn't going to get rid of the dashboard gas light. So injecting it or covering up the gas light with duct tape, masking it with drugs or cortisone injection isn't really fixing the problem either. Somebody comes along and puts gas in the tank and says, hey, by the way, what's that dashboard look like? Wow, it looks better. So I use that as a simplistic evaluation or example analogy, but it's truly the case. When you have carpal tunnel syndrome, 99.9% of every case I've ever seen in carpal tunnel syndrome need not have had that surgery. And I'm not a surgeon saying to have surgery or not, and I can't be bold enough to say that surgery doesn't work. I just respond according to what my patients tell me. Dale, who's now deceased, was a patient of mine for 30 years, worked at a major manufacturing company. Doc, he had 3 carpal tunnel releases to each hand, that's 6. 1 got infected, they reopened it, that's 7. Then they moved his ulnar nerve that on both sides. So he had 9 surgeries in less than 4 years, disabled at age 52, went on television with me on a 5 p.m. live show, said after 5 days, I'm 98% better. He started driving an 18-wheeler and he had permanent disability, was disabled at 52, millions of dollars, but couldn't use his hands. And within 5 days, he's 90% better. And he goes, well, no, if you cross your leg and your foot's asleep, don't do surgery to the foot. Find out where the compromise is. Uncross the leg, you get proper nerve and blood flow. And the same thing can happen in false carpal tunnel syndrome. There are 25 entrapments in the upper extremity from the shoulder to your fingers, 25. 17 just from the elbow to the wrist and hand, 9 alone just in the wrist and hand. People don't know the differential diagnosis between those 25. There are 17 in the lower extremity from your hip to your toes. If us chiropractors are not trained at the academic level, that's why we have what's called continuing education, where doctors such as yourself who've come to many of my courses are learning the difference and are able to help so many more people with the other $400 billion, the other half of what's spent by the NIH stating people are spending $800 billion for pain and pain suffering per year.
So it's misdiagnosis is what we're really seeing, and the inability to treat at the manual level. So that said, let me ask you, the cock-up splint, the infamous cock-up splint for carpal tunnel, how does that work biomechanically, correct or incorrect?
Okay, well, let's just discuss this. There's 2.5 millimeters of mercury pressure, same way they measure blood pressure and intraocular pressure. They also measure carpal tunnel pressure. And Chase and Whitavet and Gelberman, I mean, the list goes on and on, but I'm going to tell you Okutsu's study in just a moment. But let's just talk about what happens in the carpal tunnel. Remember, I showed you the carpal tunnel is a concave space through which nerve and blood flow and tendons that make our hand do this is right here. When you bend your hand down, that 2.5 becomes 32 to 35 millimeters. And when you bend your hand up, that becomes 50 millimeters in a normal wrist and hand. The highest measurement recorded by Okutsu's studies, and by the way, your carpal tunnel is a cross-sectional diameter approximately of your index finger. 300 millimeters mercury pressure in that carpal tunnel. So a splint or anything that causes your hand to bend in this direction is similar to what the cops would call aiding and abetting, contributing to it. So I can't say that surgery works or doesn't work. I can give you facts. I can't say that a splint like that is advised, but it's one that I tell patients, only use it if you can't sleep the first or second night. Under my care, most people have the ability to sleep with that interrupted sleep pattern because of shaking the hand and it's numb. That's usually gone within the first or second treatment on almost 100% of the cases, because we're taking the bone structure that's flattened and manipulating and restoring it, and that's seen radiographically as well. You know, it's funny, when you cut the ligament, the articles also talk it widens the carpal canal by 7 to 20%. What does that do to stability of the person's wrist? Weakens it. Yeah. And what happens when you get scar tissue, which is thicker than the original tissue? It occupies more space. So there are 2 causes of carpal tunnel syndrome where it's actually, and you asked me a question, is it false diagnosed? Many of them are. Incorrect diagnosis. If you got an entrapment in the neck and your hand is tingling, don't be diagnosed with carpal tunnel syndrome, because it's not. That's a radiculopathy, a nerve root that's pinched going down your arm. True carpal tunnel syndrome, for example, Tinel's tap test is one that you know of. If you tap it here and it tingles, that doesn't tell you the problem's in the neck. You could have double crush, multiple areas, but true carpal tunnel syndrome is median nerve entrapment at the wrist. So correcting things in the wrist, which is the bones pushing on the nerve, the same way in the foot model, okay? So I think I just had a case of foot drop because my bone model hit the floor. But What happens, the same thing with the soft tissue. If the arch collapses, then you get stretch of the arch, right? And that creates plantar fasciitis. The same thing in the canal. When the canal flattens, it creates pressure on the nerve, and the medical doctor does a procedure that they were taught many years ago in the 40s of how to cut a ligament, which has then become more refined over the years, but that's how they were taught.
What about pronator teres? That's a muscle here that has two heads on the inside of the elbow that can also grab the median nerve and can mimic carpal tunnel. How do you differentiate between the two, and what have you seen in your practice over 40 years of that as prevalence?
Number one, I have not seen a single case of pronator teres syndrome. It's the number one most misdiagnosed condition. It does not get involved in carpal tunnel syndrome. The differential, the key one for you as a clinician and for the audience, is that the arm flexors, the nerve up here affects the finger flexors, and carpal tunnel syndrome does not. So when you assess a patient, you ask them very simple, is that weakness in grip? Is it strength, or you can't close your hand? There is a difference in the diagnosis. Pronator teres syndrome, extremely rare, and many people often misdiagnose carpal tunnel syndrome with diagnosis of pronator teres syndrome. Not seen one in over 40 years, and I've seen thousands of hands.
Wow. Because I hear that a lot in the parlance, if you will.
Well, the reason you hear a lot about it is those are from people who usually do therapies in the forearm. You know, they can work on the muscles and do different types of procedures in the muscles. Look, muscles are stupid. Nerve controls muscle. I'll always go to the nerve, and I was trained very heavily on soft tissue, and I don't disagree with soft tissue, but I will tell you, if the osseous component, the bone structure, is not properly aligned, it will be the cause of what that soft tissue is doing. So I, again, go to the root. The weed would be the muscle, the root would be the bone structure.
Got it. Great takeaway. Now, real quick, because I know you have to go. I know you have pressing time. Give me the three most common ailments in the extremities that you see. And I know we may have talked about them, and three things that are typically missed that you would tell the public to make sure that the doctor that they're going to examines.
Excellent. Let's go back to plantar fasciitis. Number one, people go to different stores and they believe an item, a thing, will fix their plantar fasciitis. So they'll go to the different stores, the box stores, if you would, the specialty stores, shoe stores, running shoe stores, and they'll look for orthotics. The word orthotic means, okay, by definition, the field of study of orthosis management in English. Orthotic now has become a thing that goes inside a person's shoe. Would you rather support a condition or support a correction? If I have a broken arm at 90 degrees, it doesn't make sense to put a 90-degree angle cast on my arm. We should fix the problem and then support the correction. So my patients, we have them throw away their $800, $1,200 orthotics, donate them to me. You're not going to use those, because the moment I manipulate the bones of your feet, true or false, that orthotic would now be different, wouldn't it?
Clearly.
So why would we put a work in progress going from here, restoring what I call the architecture of the feet? Why would we put that in an orthotic prematurely? Think twice before you do that. Find a chiropractor trained in the Malley method, or fly out to see me in Iowa, like many people do, and we'll teach you and treat you appropriately by correcting the source of the problem. Getting rid of the root of the weed will keep the weed from coming back. Orthotics people have tried this, they've tried that. I mean, my goodness, we could have a nice little living off the number of failed efforts that people have tried with orthotics and braces and so on and so forth, because they've never really treated the source of the problem. So, correction, remember, support a correction, don't support a condition. Next, wrist and hand position. We've talked about that. The hand in the neutral position. I take care of a lot of very, very famous bodybuilders, trainers. The Incredible Hulk walked my wife down the aisle. I've been treating Lou Ferrigno for over 40 years. It's public knowledge. He's signed the waiver. It's all good. But putting your hand in this position to lift weights is absolutely wrong, because 2.5 millimeters mercury pressure is now 50, plus you got excessive weight compressing your wrist into extension, elevating the nerve and causing you weakness. So grab the bar completely with the wrist completely straight so that when you lift, the wrist is absolutely locked perfectly straight. The other condition we talked about was the knee, and a person ending up with runner's knee or iliotibial band or piriformis syndrome up here is often due to faulty knee mechanics, and that's whereby the tibia and or the femur are misaligned. When we correct that problem from the foot to the knee and the hip, we're helping ameliorate the source of the problem. Patients' pains remit very, very quickly. The final point was the shoulder. And the little comical joke that I do from stages all over the world, as you know, we're both international speakers. But what makes it so humorous is the majority of shoulder problems are not the shoulder. And this is even written in the University School of Medicine in Fukushima, Japan, talking about elementary kids having shoulder problems. And the problem was actually scapular dyskinesis. This great big bone right here is the number one source of most people's shoulder problems that fail. They'll have surgery, they'll have reduction, they'll do everything, but the shoulder alignment is critical for all shoulders. On the front side, you have the clavicle. So when a person has a separation, is it the clavicle going upward? Well, actually, if you take a history from the person, they actually had a pressure from the top down, which forced the shoulder blade into a wrong position. So it makes the clavicle look like it's a step-up deformity, when in fact it's a step-down deformity of the acromion, this part of the shoulder blade. Again, how you look at a coin, heads, tails, or the side, three sides to every story.
Absolutely. Great stuff. So to put it together, number one, lock in a correction, not a restriction. Number two, when it comes to lifting or putting your wrists, put it in a straight position. Otherwise, ergonomically unsound will cascade force through parts that shouldn't be feeling the force. Injury will ensue. Number three, I want to reiterate it. It's a takeaway. Untwist the twisted structures. And four, virtually all shoulder injuries or shoulder discomfort comes from the shoulder blade bone called the scapular, i.e. scapular dyskinesis. Start evaluating that scapular, docs, to help the patients with shoulder injuries. Did I miss anything?
Yes, one thing I want to add. It's not that you missed, but I want to add. You asked me earlier in this podcast, does the spine cause the extremities or the extremities affect the spine? Look, you've got four limbs, hopefully, right? Upper extremities anchor into the neck and the middle back. Lower extremities affect the what? Hips and low back. So in patients that have come to you and me and have been to others and they go doctor shopping, rightfully so, kind of like going to different restaurants. It's food is food, but it depends where you go. And the chef can make a difference. In our case, the doctor and our training. So if you would, Valix phenomena means something from here can affect me all the way up my chain. This kinetic chain, the shoulder blade, which anchors into your middle and upper back, and then right here, the levator scapula, as you know, goes up into the neck, right? And you also have on the clavicle right here, the SCM, sternocleidomastoid. So if a shoulder is twisted, it will pull on the muscles of the neck, i.e. torticollis, or other types of conditions patients present with. Middle upper back is chronic. It always keeps hurting, but nobody ever looks at the shoulder that may have been a condition or injury years ago that never got affected. And let's face it, Doc, rust doesn't produce new paint, and it takes quite a while for that to surface. So a dent in the fender may have happened years ago for you and I, but it surfaces later as a trigger, just like cancer and other diseases later in our life. So heed the message. Have a chiropractor assess all 206 bones. Let them evaluate to look and see what the root source is. If you keep getting your neck adjusted, it doesn't stabilize, it's probably not the neck, something causing the neck to continue to go out. It's the same as a ballast in one of these fluorescent lights. If the ballast goes bad, the fuse is going to keep tripping. If I keep running to the fuse box, I'm not fixing the real root of the problem. You got to replace the ballast. And I'm not saying replace the vertebrae. I'm not saying to do surgery. I'm saying find a qualified chiropractor trained in the Malley method that can look at all 206 bones and determine the difference between the root source of the problem and the result, which is the pain you're suffering and trying to get rid of with drugs, injections, and surgery.
Because the body's all interconnected. And you say balance, but we both use the term typically homeostasis, because the branch is connected to the tree and the tree is connected to the branch, if you will. Fabulous stuff. Mitch Malley, 40 years of clinical esteemed experience, national and international speaker. You know that he's treated people that we can't even mention, and he's a creator of the Malley method. I want to thank you very much for your time today. We got to do part 2.
Thank you so much. It's an honor, a privilege, and thank you for getting the word out to the public. They need to hear it.